And now, let's go to our keynote lecture to have the highlights and update on immuno-oncology in 2025, which is almost 150 years after the idea that immunological system can fight cancer. So, Professor Mascha coming from Basel, thank you for coming, accepting our invitation. It's an honor.
Thank you. Yeah, thank you very much for this very nice invitation here at this fantastic venue. I mean, it's really, I've enjoyed so much my time outside on the terrace. So next year, if it's here again, please invite me again. So just for the break. I have to say, though, that I need to leave on time because I'm jumping to the next Immuno meeting, which takes place in Munich. So I have to run to my train at point three sharply. But I think we will be able to cover a little bit about what has been happening in this very interesting field of immunotherapy and oncology in the next, 40 minutes, I would say. Thank you, Valeria, for doing this very broad introduction, which is really helpful, so I don't have to cover all the molecular stuff anymore, and come right to the clinical applications and to a little bit, looking at where does the field move, where is the place where we have to do research, and how can we integrate this in a broader way in order to serve our patients with cancer. So basically for solid tumors, what we actually do most in the clinical practice, and everybody of you who practices knows this, is we treat with the famous checkpoint inhibitors, and we've just heard a little bit about their way, how they entered the clinic, and this is just to show you that the most prevalent diseases that we are treating, cancer diseases, do actually already have an indication for those checkpoint inhibitors. Of course, not in all different treatment lines, but we have a lot of checkpoint inhibitors now licensed as IO standard of care. And it is also, I think, quite well known that the different tumor entities have a different readiness to be influenced by these checkpoint inhibiting antibodies. So there are tumors in green, like the melanomas or also the renal cell cancer, that are very ready to be influenced by these drugs because they are very immunogenic. Then there is this other part of the spectrum, like the pancreatic cancers and so on, where we think they are not so immunogenic, and then there's this middle type of tumors which have some immunogenicity. In fact, I have to say that I don't know if this image is really correct as we discuss it now. I think maybe we just don't have the right keys for the diseases on the right side. And we just have to find out what immunological mechanisms might be there that we could target in the future. But what I can say now is that for the very green diseases, we have the checkpoint inhibition in the palliative setting with the metastatic lesions. We also do have the checkpoint inhibition in earlier disease stages, like in the neoadjuvant or adjuvant space. So this is something where the goal is to integrate these checkpoint inhibitors in a way that they kind of push back the metastatic disease, that they increase quality of life, but also to increase the chances of cure in the earlier disease stages. And this is something realistic we are already doing now. For the other diseases in the middle, it is more the question to push back in the metastatic setting and to find good cooperation partners for which we have good results. And then for the red diseases, it's more like what other types of mechanisms can we find to be exploitable. So what about the question, how precise is this checkpoint inhibition? How precise is this immunotherapy? So the idea always is we want to be individualized, we want to be personalized, we want to serve the individual patient. And I think this molecular targeting with inhibitors that target a specific pathway inside the cell, the targeted treatments, they have kind of the idea that they are very precise, like we know a mutation and we give the correct drug and then it works. On the other side, this immuno field is a little bit, or everybody is thinking about it a little bit less precisely. We have this one drug fits all kind of approach where we apply pembrolizumab in everybody. We know that we don't have so much biomarkers. PD-L1 is not a good biomarker. I will show you data on this a little bit later on. We have scarce molecular data that could really direct us in any way. We have a multi-layered resistance pattern, and we think we have almost unselective T-cell activation because we have these immune side effects that we observe that show that also healthy tissues can be targeted. I would like to question a little bit this paradigm, because I think it is true that we apply the same drugs to everybody, but on the other hand, we do something quite specific. So with these checkpoint inhibitors, we are unleashing a tumor and patient-specific set of individual T-cell clones. So these are clones that are already there at baseline, ideally, that target neoepitopes that are present in this individual tumor. So this is a response that has already been primed and that is then unleashed by giving these drugs. So in my view, giving a checkpoint inhibitor, even if it's the same substance for everybody, it's something very individualized. So we unleash something that has been primed by the tumor itself. And I think that in this great work of the Rebus lab and also Pig Sauce lab that has been published in Nature 2023, I think we see a little bit this in a very clear way. So this has been a study that has been addressing the question, what makes the checkpoint inhibitor really work? So what these people have done in a very elegant way is that they kind of discovered the T cells that were recognizing these individual neoepitopes, and they were kind of enumerating these. They were kind of counting these in blood of the patients and also in the tumor. And what they have discovered is that the checkpoint inhibition works well if you have T cells that attack, or the number of T cells that attack individual neoepitopes is critical for the response. So you need to have neoepitope-specific ones, you need to have many of them, and then it works. And the other thing, and this is maybe what you can see with these, can you see my cursor? No, you can't. Here is my, yeah. So here you can see, so these different colored shapes here, they indicate the number of individual T-cell receptors that can recognize a specific neoepitope. So the neoepitope can be, for example, recognized by 5 different T-cell receptors, and if the patient has more of these T-cell receptors recognizing the same neoepitope, then this therapy will work well for this patient. And in my own immunotherapy studies, I was actually very confirmed by this data because what we have seen in our clinical trials has been something very similar, even though I have to say it's not as elegant as the work by the Rebus lab. So what we have done in different trials, this is an example of a gastric cancer trial where we treated the patients with chemo plus immunotherapy. And when we enumerated the T-cell receptors that we found in the blood of these patients, just enumerating how many different do we find, then there are patients that have very low numbers of T-cell receptors per quantity of blood, and then there are some patients with very high numbers. This doesn't represent the T-cell count, because it really represents an individual T-cell receptor clonotype. And then we say, okay, we take the median, and then we compare these patients with the many different T-cell receptors to those with the low number, then this is a very, very strong prognostic marker or even predictive marker for the immunotherapy outcomes. So this is the case for gastric cancer. It's also the case for head and neck squamous cell carcinomas treated with immunotherapy. And we have even seen this with specific sets of patients that we've treated with prostate cancer. So this is something that really is very broad, and I can say that in these trials, when we did a multi-factor comparison, this was the strongest biomarker we had. It was even stronger than the tumor load or some other clinical predictors. And I mean, the only available biomarker that we are using now in the clinic is basically the PD-L1 expression in the tissue. And if you're looking at the ROC curve for the PD-L1 expression, that means the sharper this curve here goes up, the better is the sensitivity and specificity of this biomarker. We can see that PD-L1 has a very, very bad AUC of 0.5. When we take our TCR richness in the blood as an index, we even achieve with that blood biomarker a higher AUC of 0.7. So this shows that really the immune space is the thing we need to look at. It's not only looking at the tumor, it's really understanding if the milieu, if the patient is really able to mount this immune response. And if the T cells are right, then they can really yield powerful outcomes. This is now not a study with checkpoint inhibitors. This is a study that two colleagues of mine from my clinic, Heinz Leubli and David König, are conducting in patients with melanoma. Now we've started another subcohort of patients with non-small cell lung cancer. So here, the melanoma patient had a very high tumor load in June 2024. And then what we did was we collected a specimen of his tumor and we expanded the T cells in the tumor, so the TILs, ex vivo, and then we reinfused these T cells after expansion, after activation. And this patient here went into complete remission after this TIL treatment. And so you can see if the T cells are correct, they are very, very powerful. So how can we even get better? How can we also improve the precision in these IO treatments? And I believe that there may be many ways to do this. And my favorites at the moment is first of all the combination of IO with antibody-drug conjugates. So antibody-drug conjugates are basically chemotherapy, but a little bit more directed chemotherapy. So we have really an antibody that carries this chemotherapy load and that pulls it towards the cancer cell. And I do think that this combination is really quite ideal because we, of course, do want to spare the healthy T cells in our patients that we treat with checkpoint inhibitors. If I apply chemotherapy just like that, I mean, it works, of course, but it might be better if I really apply the chemotherapy only where it's needed and spare the healthy immune space. And I think this is the reason why we have these really very good results with antibody-drug conjugates and checkpoint inhibition, for example, in urothelial cancer, where we are using enfortumab vedotin as an ADC plus pembrolizumab. And I must personally say I have never in my career had metastatic patients with metastatic urothelial cancer who were so well regarding their quality of life and who had so long remissions on this treatment. And I think it's the specific combination of these two types of treatment. And the other thing, I'm really curious to see how this evolves, but at the moment, there are no licensed combinations yet, but I think we have to pull out of our drawers these old or even newer vaccines again, because I think the vaccines that didn't have a chance to really work in an era before the immune checkpoint inhibitors. But I think there will be occasions now where we can really retry that again, because I think since we are kind of activating all the T cells by the checkpoint inhibitor, we would really, it would really be good to shift this a little more towards the tumor antigens, and this shift could be done by, for example, RNA vaccines, and I think the companies that have been very active in the COVID pandemic with their RNA vaccines, they are also investing a lot into these combinations now with the checkpoint inhibitors. Another natural combination partner, at least in my practice here in Switzerland, is mistletoe, because many patients are actually anyway using mistletoe treatments. So when I came here, I was asking myself, what am I doing with these patients? Like, what happens when they apply this mistletoe? What happens with my immune response? Am I doing something good, or is it advisable to not too much, too much push this innate inflammatory response when I want to have an adaptive immune response? So I'm very open in this regard, or I'm very curious. Let's put it like that. But I said at this point, now in Switzerland we have so much mistletoe. We have to run a clinical trial to really understand what happens immunologically, and on the other hand, also to see if this is safe. And we are now in the process of running this ISCA-check trial. So with Iscador as the mistletoe extract and a checkpoint inhibitor as the standard of care. So we are enrolling patients with solid tumors, no matter what. Apart from skin cancer, this we excluded. These patients have to be non-operable, recurrent, or metastatic with their disease, and they have to be eligible for a therapy with a checkpoint inhibitor. But they can even have concomitant chemotherapy. They can also have concomitant targeted therapy. No matter what, it needs to be a licensed combination. And these patients then, they are recruited at 4 sites in Switzerland, and they are randomized to 2 different arms. So one arm is the standard arm, where they just receive their chemo plus targeted or immune checkpoint inhibition based treatment, and in the other arm they receive the mistletoe on top, and we are working with Iscador Q, because as I learned, this is the most broadly applicable substance, so we wanted to have something that is really very broadly applicable and that we could use. So that we don't have to find a different mistletoe for every patient, which we couldn't have done. So this trial is running. I'm very curious to see what will come out. Some days ago, I asked in my lab if they have any preliminary data I could show, but of course they are still blinded, so we don't have any information of the treatment arm. But my lab is already analyzing the effects on some of the soluble immune checkpoints that are secreted by those patients. We are analyzing the adaptive immune repertoire by next-generation sequencing, and I would really be very curious to see which of these patients that, so this is, for example, soluble PD-1. This is the baseline time point, and this is the time point after 3 months of treatment. And so we know that patients that increase this checkpoint in a soluble way, also with TIM3, with soluble PD-L1, or also with soluble CD25, they don't do very well on this treatment, because the soluble checkpoint actually dampens then again the immune response. And I'm really curious to see if the mistletoe kind of separates different groups in these plots, but we'll see with time. We want to recruit 100 patients, and it's not very easy to recruit those patients, as I've learned, because I said it must be easy to recruit these patients in centers that usually don't do any complementary medicine or themselves. I mean, we are having very good cooperation with Alesheim, but we ourselves don't offer any specific treatments there. So I said it must be very easy. We offer our patients, you might have 50% of you will have another, a mistletoe on top. But then these patients say, if I enter in your trial, I want to have the mistletoe. So it is really a little bit difficult to get these patients to accept. And on the other hand, if I work together with Angela, with her center in Alesheim, I couldn't do it, because they come to Angela because they want to have the mistletoe, so it doesn't make sense in any way. So recruitment is a little bit slow, but we are getting there. Yeah, and of course, I also wanted to show this slide that we are part of the SNIO, the Swiss Network for Integrative Oncology. We've already heard, and yeah, I think this is a good option to really also combine forces in this community. So what would be other avenues towards precision IO? So looking even more into the space of more engineered kind of drugs. So everybody who works also a little bit in the hematology field knows the CAR T cells, where we kind of engineer cells to have a specific receptor on the surface that targets the tumor antigen, and then the killing is done by the cell once it is reinfused. And then there are these bispecific T-cell engaging antibodies where we kind of recruit the T-cell mechanically, basically, to the tumor cell. So these are very established in lymphomas. Basically, we don't have much to say at the moment about the solid tumors, unfortunately, but we have a first license, at least in the US, for TCR-modified T-cells, where the T-cells are modified not with a kind of an antibody, but with a T-cell receptor as a binding moiety. I will come back to that a little bit later. So why don't these CAR T-cells work so well in patients with solid tumor? Why is it more in the lymphoma field that this is working well? I think the problem is that, well, in hematology, we have all those lineage-specific antigens. They, like CD19, they are there on the whole lineage, and it also doesn't matter so much if I eliminate this lineage, because people can also in some way live without B cells. I don't think they live well without B cells, but they can. So this is a field where we can really do something that is technically not very challenging. For the solid tumors, the question of the antigenic target is always a thing, because EGFR is also on other tissues. Then there is a little bit the problem of the penetration of these cells. How do they get into that fibrous kind of core tumor? How do they penetrate there? So there are a lot of things, then they get exhausted very, very likely. But I mean, we don't want to focus on the problems. We want to look ahead. So what can solve our problems? And I think there might be different ways. But what I really like a lot is the work of Andreas Mackensen from Erlangen with this BioNTech consortium, who have said, well, can't we just combine these CAR T cells that, for example, against Claudin-6, which is a tumor antigen not so much expressed in normal tissues, by applying at the same time an RNA vaccine with this same target. So in order to really push these immune cells once they are in the body, and to make sure that they are not lost, but they are really re-expanded. So why did they think this could work? I mean, they did animal experiments, and here you can see after the infusion of the T cells, they can actually be always re-boosted when you give the vaccine. So I think this was a great idea, and I think a very novel idea how to solve the problem. And the good thing is some novel ideas don't work, but this novel idea I think really works. So that is the phase 1 study, and I think you can just concentrate on the blue bars here, because these are the bars with the patients that have received the target dose. And here you can see for these very pre-treated patients with ovarian cancers, with all kinds of testicular and whatever cancers, you can see a lot of responses and only few patients that did not respond in that setting of really pre-treated disease. So this is, in my view, a real exciting frontier that make precise CARs maybe even more potent. The other thing I would like to venture a little bit more on is the question, do we always need cell surface antigens as targets? So cell surface antigens are great. They are at the cell surface in a very high, or often at a very high density. So you can take a simple antibody as a binding moiety. So in the case of CAR T cells, the binding moiety is a single chain FV, but this is nothing else than a very short antibody. So we arm these T cells with something that comes from the B cell, so with this antibody, and then we bind the cell surface target. The only problem that I already mentioned is that the number of available cell surface targets in solid tumors is very limited. So if we could really have access to something that is that could be even more helpful than this, in my view, would be the intracellular antigens that we have. So how can we target an intracellular antigen with something that doesn't penetrate the cell, like a cell treatment? Well, you could target an intracellular antigen by targeting the peptide of this antigen that is presented on every cell via the MHC molecules. We have the mechanism that every protein that is inside the cell is actually cut into pieces and then presented by MHC class I molecules on the cell surface. This helps our body fight infections, for example, in viral infections. When I have a virus inside the cell kind of cuts down these pieces of the virus, presents on the surface, and the immune system knows, well, there's something going wrong, I need to eliminate the cell. So this is the way it works with the MHC. And if we could take something that can bind an MHC with a peptide, then we could venture even on targeting intracellular antigens. And what can bind an MHC with a peptide? A TCR, a T-cell receptor. So we need to enter into that space of the T-cell receptor a little bit more, I think, because then we will have a wider variety of targets. This targeting principle, of course, comes with restrictions, because when I'm talking about MHC targeting, then I'm always talking about a targeting principle that is always dependent on the MHC type of the patient. So it's not like allogeneic stem cell transplant, but still, I can, if I have a TCR that targets a peptide, this will only target this peptide in a specific HLA setting, for example, in HLA-A2 patients, which is the most dominant in the Western world. And this is also the reason why these TCR-based treatments, they are made, I mean, we have to say like that, for the Western market, so they are all basically HLA-A2 restricted. So patients that have not HLA-A2, they cannot have these treatments. So the idea would then be to really expand this on other types, but patients with rarer HLAs will not benefit from these approaches. Nevertheless, I think we need to start somewhere, and so the idea is to take this MHC class I with a peptide and then to develop something that binds it. And there is, as I said already, one product licensed in the US, which is afami-cel. And this is a TCR-modified T-cell that recognizes MAGE-A4, which is a tumor-specific antigen, so the peptide of this MAGE-A4. So this is licensed for synovial sarcoma, so it's not only HLA restricted, but also restricted to a very, very small, tiny population. But as I said, we need to start somewhere. The other thing is something that is also licensed here. You might have already given this to a patient, which is tebentafusp, which is a bispecific T-cell engager, but that doesn't use an antibody binding moiety for it, but a T-cell receptor. So I mean, it's not really a T-cell receptor anymore in my view, because this T-cell receptor that recognized the GP100 that has been used to construct the tebentafusp for uveal melanoma has actually been genetically modified in a way that increases its affinity 1 million-fold. So it's basically, for me, it's an antibody now, but it still recognizes MHC. So this is nice. I don't know how many of you have already treated patients. I have to say my personal experience is not that great. Patients suffer from fever. In many cases, there is no response, one has to say critically, but we are kind of working on it, I think. So targeted cells or cell products to a specific treatment lineage that you can buy for your patient is very nice. But what could a future of cellular treatment also look like? And I think this must be more like haute couture. So an individual cell product that is really made for the patient. And I mean, this is not really easy because you know all the regulations. We already have difficulties with our product that are not targeted to the individual patient. But if you don't dream, then you will never get there. So what we are doing in the context of an SNF-funded project now is something that I have been actually developing from the first thought 20 years back to now, because I have been working a lot on the topic of what properties do actually B-cell receptors of B-cell lymphomas have. And we have, my lab has actually analyzed a lot of these structures of the B-cell receptors that are expressed as part of the B-cell receptor on the lymphoma tumor. And they actually do have specific sequences in this B-cell receptor that makes them be able to do autonomous signaling without recognizing an antigen. And these sequences, they are shared between different patients. So they are stereotypic motifs. So this is the case of a real surface antigen, of a membrane antigen, not something with MHC, but something that is really there on the surface in its complete protein form and which is shared between patients and which is something that the normal immune system doesn't have because these sequences, they are really toxic. They make the BCR aggregate and signal on an autonomous fashion. So I said, why don't we take an antibody against these stereotypic sequence motifs and either couple it with an anti-CD3 in the context of a bispecific or in the context of a CAR. And the CAR work we've already been able to push through the preclinical stages and published last year. So here you can see the green stuff here is dead lymphoma cells. These lymphoma cells have been treated with this CAR T cell that recognizes a specific point mutation in the B-cell receptor of this lymphoma. And this is a control lymphoma without this stereotypic BCR. And you can see that you don't harm anything. And also with the normal immune cells, the normal B cells, they remain completely untouched when you apply these CARs. Now you can say, well, for lymphoma, we have the CD19 CARs. Why would you venture on something different? I think, first of all, we have patients that relapse after CD19 CARs and that have lost CD19 expression because CD19 is not essential for the cell. They can just lose it without dying. With these BCRs, it's something different because the cell really needs it because the BCR is a tumor driver for the lymphoma. So they just can't do without this BCR, so they also can't really develop, in my view, we haven't tested it, but I think they cannot develop resistance because they may not be able to lose this important protein. So I think either in relapse this might be an option or even as a primary treatment because it's less resistance prone, so to say. The other thing that I said, this hasn't been published yet. This is the first data that we're producing. I mean, we had to first set up in our lab the ability to actually produce these bispecific T-cell engagers ourselves. I haven't never done that before, but now we have it running. And we have constructed this first BiTE with the same binding moiety as for the CAR, and then for an anti-CD3 here. And then we are applying this in the cell culture, and this is the control with the anti-CD19 blinatumomab, which forms these dead clusters here. And you can see that this point mutation specific one does the same, but the difference is that the normal B cells are not killed by this B-cell receptor engaging bispecific antibody. So to sum this a little bit up, I think immunotherapy nowadays can be highly precise. Even the checkpoint inhibitors, where we say, well, they just turn on the T cells, they are precise. They unleash something that has been primed before. The TILs also, I mean, these are TILs that derive from patients that we kind of expand and make more sharp. Also, the boostering with target-specific vaccines that might even work for complementing the actions of CAR T cells is something that we should watch in the next years. And the engineering to target surface-exposed point mutations or sequences needs to be followed up, I guess. This is a little bit, like this. The next question is, what is the interaction of conventional immunotherapy with complementary medicine? I think it's a very important question because it's often practiced, even if you don't maybe know of it, as a doctor that is not so involved in complementary medicine. But it's not well explored. And I think we need trials to really put us on the safe side for these treatments and to also understand a little bit what substances like mistletoe that are believed to be immunostimulatory actually do in the context of these molecular drugs, I would say. So encapsulating a little bit the essence of precision oncology at this meeting, I would still say, despite this whole molecular background, we have to find the right treatment for the right patient at the right time. This is our job, and thank you for your attention.
Thank you, Mascha. Fantastic talk. Congratulations to this work. Do we have some time for questions? We have
I just had to watch your watch.
Okay. So thank you and congratulations for your work. It's really impressive. So it's a full immersion in the immune receptors. And I have the first question to the TCR work which you did, because we lack of good biomarker. Absolutely. So is this TCR something we can start to use in the routine, to validate who is measuring this in a good way? Is this possible?
This is the really crucial thing. I mean, we have been working on this for years now. All of our immunotherapy trials have been backed up with translational programs where we measured this. Still, we are not in a position to really offer a standardized approach to measure it. There are companies on the market that do repertoire sequencing, but everybody does something different. We are doing something different. I don't actually have the power to also at the same time set up all the, be qualified as a kind of reference lab for something else, because this is not my primary. So I want to understand this. I think other people have to take over at this point, and I'm talking to our colleagues from the pathology to take over at this point where we can use it in the diagnostics. And I think in Switzerland, where we are not so restricted with the diagnostics, where we can offer something even without a big. So in Germany, it's very difficult to offer a diagnostic test and to get the companies pay for this. Here it would be much easier, but I think you need a lab with a real focus on translating this to a validated kind of test. Yeah, but then you could use it.
That would be fantastic improvement in biomarker. Some questions from the audience? You have 7 minutes. Or some question from online? So you are very exhaustive. Thank you very much. I have also to congratulate for the study. You are starting with the mistletoe, so we are very grateful that you have the power, the idea to make it, and we will be certainly very happy to collaborate with you.
Thank you.
Thank you very much.
Your last slide was give the right treatment at the right time. I think there's existing data about the question when to give the immune checkpoint inhibitors. Could you comment on this?
Yeah, well, I think this is a very heterogeneous field. I was actually thinking when I first started with this research, also when these checkpoint inhibitors entered the clinic, that we have to push them into the first the early lines, because then you have these not so much exhausted T cells and so on. And also there is this idea that the thymus is kind of degrading so rapidly after the age of 20 that you will not be able to, at a higher age and after many treatments where your T cells have already come down, you will not be able to regenerate this T cell space. And this is something that I don't believe nowadays, after having done so many sequencings. I think your thymus will work when it's needed. So we have actually treated 80-year-old patients with fludarabine for CLL, and then we measured the complexity of the T cell space before and after, and they completely regenerate to normal levels. So I don't believe that. I think you can always make your thymus work even after many rounds of chemotherapy, and I'm not so critical about this pushing too much. So frontline always better, but I think you can also be successful in later lines.
Okay, thank you. But I thought a little bit different about the question. The question was, is it better to give it during daytime or during nighttime? Because I think there is existing data that it's different.
Yeah, well, I know one study that I looked a little bit more closely that you have that said that the effectiveness is better in the morning. The thing is that I'm not so sure, like looking at the trial design, I'm not so sure if it's really valid to say this, because when I look at my patients, the frail ones come later. So in the afternoon or at around midday, and the not so frail people that want to go to work, they come in the morning. So I'm not sure if such a non-randomized kind of study design really answers the question if there is a circadian kind of rhythm and if you should do it in the morning. I'm not convinced. But I only know this one trial. I don't know any others.
Any further questions, comments?